Thank you, Dr. Pawan. It's always a difficult challenge to follow Suresh, but hopefully he's woken all of you up and I can continue that and keep you awake. It's a pleasure to be speaking here. My talk is going to be very different from what we have been hearing so far, although there's some aspects of statistical learning and AI that some of you have heard before. What we tried to do was a simple thing. We wanted to identify which individuals ulcers would not heal when you take when they come to the clinic, right? That would be the ideal case scenario if if the doctor knows, the patient knows that their ulcer is unlikely to heal using current state-of-the-art treatment technologies, because then something else could be done. And this is very common. Only about 60 to 70% of early stage or low-grade foot ulcers heal. And so we try to do, we try to characterize immune cells and biochemical variables from the blood and try to develop predictors for non-healing of ulcers. So the basic premise here is that there are three different features that affect foot ulcer healing or development and healing: neuropathy, vasculopathy, and the immune mediated inflammation. But a majority of treatment strategies focus on neuropathy and vasculopathy. Inflammation is rarely treated at the foot ulcer site. And that's something that we were interested in, and that's how we got started. And as we started doing it, we realized that there was not much information available about the inflammatory changes apart from a few cytokines and some activation of leukocyte markers about what's happening in the patients with diabetic foot ulcers in terms of immune cells specifically. So our lab, which has expertise in characterizing immune cells, isolating them, and understanding their phenotype and function, went about trying to do this for patients with early stage low grade diabetic foot ulcers. And the question we asked was, are immune cell phenotype changes a predictor for healing or non-healing of ulcers? And we developed this hypothesis, and we took this up in a study design that was in collaboration with Dr. Pawan and his colleagues at the Karnataka Institute of Endocrinology Research. We enrolled our power analysis from previous studies that had been published using proteomic analysis, which is very different but still something that we had to go by, showed that we needed at least 52 individuals for a study that will be statistically powered appropriately. And knowing the sort of dropout rates that we see in India, we hope to enroll 80 individuals, and eventually it became 85 and we got our 52 individuals. And we primarily focused on grade 1 and grade 2. At that time it was Wagner classification. With the new Wi-Fi classification, it's 100. All the patients who got enrolled in the study had ulcers that were 100, no infection, very early stage, only neuropathy, nothing else. And a 4-week follow-up of these patients was carried out to understand if their ulcer were healing or not healing. And simultaneously, at the time of enrollment into the study, when the first sort of foot reconstruction or debridement is done, we collected blood from them for biochemical analysis as well as immunological analysis. This is the sort of demography and basic biochemistry of the patients who were enrolled in the study. As you can see, these were the standard profile of patients that you would see in a government health center in India. 50 to 55 is the age group, usually around with the median around 52 to 53. The body mass index doesn't indicate that they're obese, but that's common in India with the lean fat sort of individual. What is interesting and what is the most I would say sad result is that many of them come to us with very high HbA1cs. I should say come to the clinicians with very high uncontrolled blood sugar levels. As you can see here, 9.35, 9.3 was the median. We in fact did not see anybody below 8, and this is still grade 1, grade 2. So you can just imagine what would it be for patients with worse grades of foot ulcers. In these individuals, we performed sort of a follow-up, and then we saw that among grade 1, about 33% do not heal with the state-of-the-art treatment. That treatment did not change. Whereas in grade 2, about 36% did not heal. And this is standard. This is what people have seen across the world. 60 to 65% of the individuals with grade 1 ulcers, the state-of-the-art treatment strategies will heal. 30 to 40% will not heal. And that's what we see in this center, which is matching up with what everybody else is seeing. In addition, what we did was, and this is the only slide where I have some methodology that may be different from what you've seen before. This is sort of a flow cytometry analysis of immune cells. What is shown here is basically cells that we take, the blood cells, isolate only the immune cells and run them through a flow cytometer here, and we get this sort of data, and we can then classify these cells into neutrophils, monocytes, and then each of them have different markers. So we looked at all of these different markers. Sorry about that. This is similar to what would be done in anybody with an oncology patient. So most tertiary care centers which treat patients with cancer do this sort of analysis, but maybe not this much, maybe not all the different markers that we have tested. But most of these markers are markers that are present when inflammation is present. They are upregulated if the cells are activated in some form, and we wanted to really understand how the immune cells are activated in individuals with diabetes. And so eventually what we do is collect this sort of data. I don't mean to scare you. You don't need to look at the numbers. You don't need to look at this. This is basically the idea of, this is the sort of data you get. We have 52 individuals in the rows here. So what you see here, 52 individuals, and then about 40 different parameters, 31, 16 from clinical and biochemical, 15 from immunological, and then we have some urine and other parameters. So a total of 41 parameters among 52 patients. And this is not usually is not going to give you good results if you do traditional analysis, statistical analysis. This is where what we call statistical learning in the 1900s or early to 20th century, what now has morphed into machine learning and artificial intelligence. Those are the sort of tools you apply to this sort of data to get the best results. But if you apply any sort of traditional techniques, you get this sort of matrix, right? This is the sort of thing. So what we have here again, same thing, patient IDs, separated as grade 1 or grade 2, healed or non-healed, and some of the major parameters that we measured. And if you just look at this, this looks like a mess of a plot, and that's the idea, to show you that there's nothing happening here. If you do a traditional analysis, you're not going to pick up anything. Basically what we saw was no single parameter, that is not HbA1c, not fasting blood sugar, not age, none of that correlated with healing or non-healing. And that was expected because others have done these studies and have not seen anything. But with this sort of data, you can do, and we saw this in an earlier talk, you can do conventional analysis or this learning-based approach, supervised or unsupervised learning. And we decided to take a supervised learning-based approach because we know something about these foot ulcers. And we sort of did this sort of univariate analysis, looking at individual samples. And so we looked at LDL cholesterol, we looked at some of the markers here. These are markers on monocytes. These are different markers. And you can do this sort of ROC curve, receiver operator characteristic curve analysis that you may have seen for cancer patients, that you may have seen for heart disease. And then you come up with these parameters and say, okay, LDL cholesterol by itself is not a very good predictor. 0.61 AUC can go from 0 to 1. Closer to 1 is a better predictor. Anything below 0.8 is considered not that great, right? But 63%, by the way, if somebody goes to the clinic right now, comes to any one of you and says, I have a foot ulcer, your ROC of just predicting whether they'll heal or not heal is about 0.63 based on our data. So it's not great, right? We want to get to above 0.8. How do we get to that number of above 0.8? So what we did was we took all the biochemical data and ran a k-means clustering and other supervised learning based approaches to look at parameters that may actually predict non-healing. And we saw that a combination of certain parameters, total cholesterol, LDL cholesterol, triglycerides, and the other two are neutrophil and monocyte percentages, which you get from any CBC. Together, not individually. If you take any one individually, it won't be a good predictor, but all 5 together can be a good predictor. In fact, the AUC here shows as 0.82. So what we show is that just looking at these 5 parameters that most of you will have data for amongst your patients, if you look at all 5 of them together and apply our statistical learning approach, which is a very simple approach, anybody could do it, you get a much better prediction of whether that person is going to heal or not heal with the current state-of-the-art treatment strategies. We did the same for our immunological variables, which is something that we analyze in our laboratory. These are not standard variables that are not present in standard diagnostic labs. And what we saw was a combination of various parameters on neutrophils and monocytes. These are activation markers. I can go over this, but I'm not really going to spend too much time. These are basically adhesion markers and activation markers, which are normally present on immune cells and get upregulated upon inflammation. Together again, all these 5 can predict non-healing, at the same rate as the biochemical variables. So what we are showing is you can combine the diagnostic data from biochemistry, or you can combine the immunological data and still get better predictions than just what you can do right now, right? And so then we said, if you have all of this data, now you combine all of the data, both the immunological data and the biochemical data, and come up with can we come up with a better model? And that's what we did here, and we did come up with a better model. The AUC here is 0.87. It's not perfect, but the analogy here is that means at 87% confidence for us in predicting whose ulcers are not going to heal, which is much better than what is currently available in the clinic, right? And what we have here are simple parameters. Total cholesterol. The lower the total cholesterol, the worse the outcome. That's what our model suggests, but not individually, in combination of the other three parameters, right? The higher the LDL cholesterol, the worse the outcome. That's sort of expected, right? Higher the LDL cholesterol, but this is for healing, not for development of foot ulcer. For development, we didn't see this thing. For healing, we saw that if the person has already developed a foot ulcer, the higher the LDL cholesterol level, the lower the chance of healing. In combination with the higher the percentage of monocytes. So if they have higher monocyte percentages in circulation, which is a classical marker of inflammation, then there's a lack of healing. At the same time, we can also look at one specific marker called CD63. If it is lower, it means that the person is not going to heal. CD63 is actually a suppressive marker. The higher it is on monocytes, the more the monocytes are known to be suppressive. So this is sort of an inverse correlation here. And if you can collect data on these four parameters, we think that you can predict better about whose ulcers are not going to heal. And that's what we recently published. We said that if you look at these four parameters, at least in our cohort of 52 individuals, we found that we could really predict foot ulcer non-healing very well. So what does this mean, and what do we think that we can do next, right? This means that we can predict and we can provide better information for clinicians treating foot ulcer patients as well as to the foot ulcer patients themselves. But we need to do this and correlate this in a better, larger cohort. And so we are in the process of trying to set up a 500 patient cohort and very simple biochemical and immunological analysis that can be done in most tertiary care centers, and follow up of the patient to understand if they're healing or non-healing, to confirm whether the parameters that we have measured are good enough to predict non-healing. And if they are, we could potentially change the way we're looking at treating these patients. In addition, something that I've not mentioned here, but I thought I'd mention based on all the talks that are going on, we've also been developing technologies for drug delivery where we put various drugs, and this is what Dr. Pawan mentioned as a technology forum thing, into polyurethane scaffolds or chitosan scaffolds, which are used now for healing of foot ulcers. And those drugs, we can tune the rate of release. And we have shown in using an animal model for diabetes and diabetic wound healing that using immunosuppressive agents that are also antibacterial can promote wound healing, because some of the immunological markers that we show tend to go down once we have drug that's applied only locally. So no systemic administration, which means toxicity, side effects, all are reduced, but local application of this drug in the polyurethane foam or in a chitosan foam will actually promote healing. And that's something that we are still in, it's in the laboratory, it's been tested in animal models. We would like to see if we can take it forward into clinical testing, or even at least some preclinical models of testing. With that, I'll stop and thank a lot of the people who did the work. Most of the work was done by Jayashree here, who was a PhD student. Well, Dr. Jayashree now. She's pursuing her postdoc at Harvard Medical School right now. And the other person who's involved primarily in the study was Vinod Durai, who's now a PhD student in my laboratory. He worked with Dr. Pawan quite a bit in establishing this cohort. And with that, I'll stop. I'll leave you with this slide and happy to take questions. Thank you.